This is IAQ Radio, Indoor Air Quality Radio, the voice of the indoor air quality industry, with your hosts, Radio Joe Hughes and the Z-Man, Cliff Zlotnick. And now, Radio Joe Hughes.
Good day and welcome to IAQ Radio Plus. This week is episode 608, and we welcome Dr. Lisa Brosseau. Before we get started, let's thank our sponsors. We're going to talk a little bit about COVID-19 and control banding. It's going to be an interesting discussion, a pretty popular technique in the industrial hygiene world. But before we get started, let's thank our sponsors. Our newest sponsor, returning sponsor, is Grey Wolf Sensing Solutions. Learn more at greywolfsensing.com. Our marquee sponsor, Instascope, the future of IAQ assessment, unlimited sampling with instant results at instascope.co. Association sponsors are the American Industrial Hygiene Association at aiha.org, the American Conference of Governmental Industrial Hygienists at acgih.org, the Cleaning Industry Research Institute at CIRIScience.org, the Indoor Air Quality Association at IAQA.org, the Restoration Industry Association at restorationindustry.org, the Institute for Inspection, Cleaning, and Restoration Certification at iicrc.org, and Healthy Buildings America 2021 at hb2021-america.org. Industry sponsors are AEML Laboratories at aemlinc.com, Particles Plus at particlesplus.com, and Healthy Indoors Magazine at healthyindoors.com. What I'd like to do is introduce Dr. Lisa Brosseau. Now retired, was a professor at the University of Illinois Chicago School of Public Health from 2015 to 2018. She was the director of the Illinois Education and Research Center, which supported graduate and continuing education for occupational health and safety professionals and continuing or community outreach activities. She was also the director of the UIC Center for Healthy Work. She began her career as an academic researcher and educator at the University of Minnesota School of Public Health, where she directed the Industrial Hygiene Program. Welcome to the show, Dr. Brosseau.
Thank you. I'm glad to be here.
Great to have you with us. Let's jump right into first. I want to get an idea of how you got started in the industrial hygiene field, a little of your background, if you would. It's kind of unusual for people to, I always wonder how people got started in industrial hygiene.
Right. I was going to be, an oceanographer or an environmentalist like Rachel Carson, because that's the time period I grew up in. And I took environmental studies in my undergrad before it was even a major, so I sort of made it a major. And then I started looking for jobs, and the only jobs I could find were with oil companies, and that wasn't exactly what I was looking for. I ended up working for an insurance company doing safety consulting, loss control, as they call it. I talked to a few industrial hygienists, and they said, this is what this is the kind of job you should do if you don't want to go back to school right away. And that was a great training ground, 3 years of out on the road inspecting workplaces. I learned a huge amount, and I realized how little I really knew. And then I applied to a master's program. And when I was done with that, I just decided I loved being a student, and I stayed for my doctorate. And I realized I wanted to be a researcher and academic. So, but industrial hygiene appeals to me because there's always a problem to solve, another problem to solve. And it is, you're helping people. It makes a difference to people, and you get to use science. So all those are what appealed to me.
We talked a little yesterday before the show. You mentioned that Alice Hamilton was one of your heroes, I guess. One of mine as well. Fascinating person, and it's great to see. I think younger people are starting to get more involved in the industrial hygiene world, and also seeing more females and minorities. It's great to see. It's because we're losing a lot of the, you're retired now, and a lot of the folks that have been in the business for a long time are, slowly retiring. How do we get more how do you think we get more young people interested in the topic?
That's a good question. I think more of them are becoming interested in public health, and that might be that's one good way. If they go into public health, they don't really know what it is anyway. And we found that to be a good recruiting ground. Also, people who think they want to be physicians or nurses realize that occupational health and safety can be very rewarding. And you get to work on the front end, right, in the prevention area rather than in the treatment area. So that's also appealing. I think kids just need to understand how much fun science is. It's not about memorization. It's not about knowing a ton of facts. It's about solving problems, and problems that are really important to people. Maybe climate change is going to get more people interested in science. Kids realize the world around them is really important, and we have to do what we can to protect it.
Well, this current topic we're going to talk about today, and you mentioned public health, and I think you're dead on that a lot of more people are getting interested in public health and learning about it. Let's talk a little bit about how those two are kind of coming together right now. We want to talk about control banding. First, if you could tell listeners what your definition of control banding is, and maybe how it's used in the industrial hygiene world.
Sure. Control banding started out in the pharmaceutical industry. They were the first to realize that they were never going to be able to come up with enough exposure limits in a timely manner for all the different hazardous materials. And they're very hazardous because, of course, they're chemicals, right? And you only need small amounts of them. So any worker exposed to a small bioactive material is going to could have serious health outcomes. And so but all they usually had was some animal toxicity data and not much epidemiology. So they realized that if they were going to protect workers, they had to come up with some other way to make decisions about what controls should be in place for different medicines and pharmaceuticals that were being manufactured. And so they came up with a way. It basically allows you to allocate the material itself and the task of people doing into bands, and those bands then give you some guidance about what to do to protect people. And that's why we call it control banding. And it's a qualitative method, but it's informed by science. It's informed by professional judgment. It has a systematic way of making decisions, and that's what as a researcher and a scientist, I think it's really important that industrial hygienists and scientists in general use a systematic process for making decisions, whether it's quantitative or qualitative.
Interesting. Let's do this. We have a little PowerPoint presentation you sent, and I'd kind of like to use that to see how control banding would be used with COVID-19 and in helping with determining what types of responses and protection we need for COVID. John, let's put up that first slide. There we go. Go ahead, Dr. Brosseau.
Sure. So, and those who've watched my webinars previously are going to recognize a number of these slides. So, instead of the hierarchy of controls, which is a very traditional way of thinking about controls in a priority order for industrial hygienists. When it came to thinking about infectious diseases, and especially ones that might be aerosol transmissible, it occurred to me and colleagues that maybe there was a different way of thinking about this. And part of the problem was that we're trying to cross some different fields when we talk about infectious diseases. We're trying to include physicians, nurses, healthcare, infection control, prevention folks, and they think about the hierarchy of controls a little differently than we do. So, but they do recognize and understand this Source-Pathway-Receptor approach. So basically, a source is the person, in this case, who creates or emits respiratory aerosols or respiratory emissions of some sort, fluids that contain infectious material. And I've circled this person in a call center. These are pictures of places where we've seen clusters and outbreaks, and there have been a lot of those in workplaces. So a call center, it's a lot of talking, people are sitting near each other, so anybody could be a source. And then eventually, as that person talks, you have the creation of, the generation of aerosols, and those aerosols eventually spread throughout the whole space. And then they reach a receptor. So keep pushing the buttons here. There we are. So the aerosol particles fill the room, and then you end up with someone as a receptor. And that receptor, of course, the person right near a source is at most risk, but eventually push the button one more time, you'll get to anyone can be at risk and anyone can be a receptor. So that's the sort of underlying way of thinking about this. And that gives us a way to think about a hierarchy. You should start at the source, work your way through the pathway, and then if you really have to do controls at the receptor, those are usually like personal protective equipment, but we need to focus on source and pathway first. So that the next slide, oh, sorry, I should wait and see if you have questions about that.
Well, I just want, if you could go back one, John. Now, I think we're making the assumption here that this is an aerosol transmission as opposed to droplet. Is that accurate to say?
Yeah, that's a good question. And that is what I usually start with when I talk about this subject, is that aerosol exposure is probably a more important method of transmission than contact or droplet. I don't rule those out entirely, but droplet transmission usually is defined as coughs and sneezes and large particles and being very close. And we're seeing a lot of asymptomatic transmission. So that would mean people there isn't coughing and sneezing going on. So that argues for, and we're also seeing transmission in spaces that are larger than just 6 feet apart, and transmission beyond 6 feet. So that suggests that there are particles that are being distributed throughout an airspace, and that and it's inhalation. And aerosol transmission implies inhalation, both near the source as well as far away from the source. So yeah, you're right. I focus on aerosol transmission.
Okay, and I think that was important to set up as we go through this, because, and
Yep.
I guess I have a question for you on that too. So let's say our droplets. So as I speak, there are droplets, small droplets that come out. They drop to the surface pretty quickly, but then they dry out, and that particulate that was within that droplet is now more likely to be re-entrained. Is that accurate to say?
It is. Actually, we generate particles across a wide range of sizes, all the way from less than 1 micron to, well over 100, especially if there are coughing or sneezing. So, and what happens with those larger particles, you're right, they evaporate, and evaporation is actually really quick, usually, especially at lower humidities. And I noticed somebody's asking about humidity, and humidity can play a role, but in a typical 40 to 50 or 60% relative humidity, you're going to get fairly quick evaporation of larger particles to smaller ones. And it usually happens before they deposit or settle due to gravity. So you actually end up with many, many smaller particles, lower than, say, 10 microns or 5 microns. And those are particles that can stay airborne for quite a long time, more than minutes even. And the smaller you get, we're talking like hours and maybe even days. And those are all those particles I talked about are inhalable, but particularly the ones that are lower than, say, 10 or 20 microns. They'll land in your nose, or they'll make it down into your respiratory system.
Which I think just adds to the weight of evidence that, there's probably very likely aerosol transmission, but frankly, we just don't know for certain. Is that accurate? And we don't know what dose is necessary to cause someone to develop symptoms and or to go into a full-blown case of COVID-19?
Oh, there's two other talks.
Okay.
So I give a talk about aerosol transmission, and you're asking just the right questions. You know, how much exposure is there, and is there going to be an infectious dose? And you're right, we don't actually know about the infectious dose for this organism, but I suspect, based on animal studies and what we know about similar organisms like influenza and SARS, that is probably fairly low. And by fairly low, I mean around maybe 100 or 200 virions, virus particles. What we don't know is how many virus particles people emit, you know, infectious ones, viable ones. We don't actually have very much data. There's one study with exhaled breath that does suggest that we emit a lot of viral RNA in our, you know, that's what they measured in particles that were exhaled, but they didn't measure viability. So we don't know how much of those particles are actually going to cause infection. And then we don't actually know how many particles you have to get to be infected. But in terms of biological plausibility of aerosol transmission, like I said, that's a whole nother talk I give. There's a lot of data to support that. There's data to support that. Of course, we generate aerosols when we speak and talk and breathe and sneeze and sing. And for influenza infected people, they've been able to measure both viral RNA and viable virus in people's emissions. So, and also for people with other forms of coronavirus. So there's no reason to believe that wouldn't occur. And there have been there's been a little bit of air sampling in hospitals, especially, that have shown both viral RNA and viable virus, culturable virus. So I would say we have plenty of evidence to support that there's viable aerosol generation from people. You know, the pathway, we know as well, this is an organism that survives for a while in air, based on some experimental studies, at least a couple of hours. That's plenty of time for an aerosol to get distributed in a space. And then we know that the receptors for this organism, the ACE2 receptors, are located throughout the respiratory system. So those are all the three criteria you need for biological plausibility, and I think they're well satisfied.
So let's go to the next slide. I wanted to kind of set the table and make sure we had that background stuff down first before we get into more detail here. So now
Sure.
We're into examples of source control.
So the next couple of slides are just going to give some examples of how you might think about controls in these three buckets: source, pathway, and receptor. So source controls I usually think of as what can you do with respect to the source, which is people. People are mobile point sources, basically. And obviously what happened early in the pandemic in many places is the recommendation was for as many people to stay home and work remotely. Some of us are still doing that as possible. Of course, there are many essential workers for whom that was not possible. There's been the addition of screening and testing as time goes on. Screening isn't always very effective if people don't have symptoms, but testing can prove to be effective, especially if you do it on a fairly regular basis. And then you have more assurance about the fact that there will not be sources in your workplace. And of course, you could adjust the work schedule to limit the number of people or the time that they spend in a space. So those are the things I would recommend for source control. You notice I didn't put face coverings on the list because I don't think of them as very good source control. So if we go to the next slide, that talks about pathway controls. And pathway controls, basically, we're trying to break the distribution of particles from a source to a receptor. And those people have they're using a lot of barriers. That's what that top picture is showing you. But I'm not convinced barriers are going to do a lot of good for aerosol transmission over time, because you're going to get distribution of particles all through space. They might prevent the transmission of larger droplets directly forward or maybe to the side. But I don't see barriers as being a really effective solution. But I do see increasing the number of air changes per hour, possibly, changing the way people interact with each other. There has been discussion about physical distancing, and unfortunately that works only, a little, because certainly it prevents you from being exposed directly to the air emissions from somebody, the respiratory emissions from somebody nearby, but eventually you'll get distribution of particles throughout the space. So, in industrial settings, we would use local exhaust ventilation. And wouldn't it be nice if we could all just have our own little LEV hood that we could all walk around with? But yeah. Until we figure that out, these portable air cleaners might be a good solution to making sure that we really have the air changes per hour and the air cleaning in the space.
Okay, so we've done source pathway. Now let's go to receptor controls.
Right. And, I throw control booths in, or, booths or spaces that isolate people. I'll show that in a little while when we talk about the example for control banding. Those might be pathway or receptor controls, but basically you're trying to protect the person who's not infected but could be infected. But usually we talk about personal protective equipment in the context of receptor controls, and that would be respirators, not face coverings and not surgical masks, neither of which have very good filters, and they don't fit very well, and they don't prevent outward leakage. If you wear a fit-tested respirator, you have both good source control and good personal protection. So that's what I have been focused on in workplaces, is if you really can't get all those other things to work, then a respirator is the best solution.
Let me go. There's a text question here, and I want to kind of use that to demonstrate what you're talking about. And that is the use of positive air pressure is used to move clean air to dirty air. Can you comment on the use of air pressure to control air movement? And then if you could let me know, which of the three buckets does that fall into?
It's a good question. I think it probably falls into the pathway control. And a positive pressure or negative pressure, that's actually used a lot in healthcare settings where you can separate wards or separate spaces, negative pressure isolation rooms. You can use pressure to ensure that that dirty air doesn't move into a clean space. I think in offices and commercial buildings and other workplaces, that's a little bit more complicated. Certainly we use it in clean rooms and some other work settings, but it's, even in hospitals, it doesn't always work, right? So I'm sure you've probably read those research papers that have gone around and evaluated negative pressure rooms in hospitals, and you often find that they don't actually operate the way you expect them to. They're hard to get them to actually continue to maintain the pressure differential. So, but I think it has a place, but it's complicated.
Well,
right?
and I think when we get into your example later of a bus driver, I think that might be a good time to revisit this question.
Right.
All right, let's go to the next slide then, John. This third bucket would be, or did we get to the receptor bucket yet here? Yeah, we did. Okay, so we did the receptor. So we set the source, the pathway, and the receptor. Now let's go into the actual control banding, and I'll let you take it on here.
Sure. So the two articles that talk about control banding that are relevant to this discussion are listed over on the left. The first was one I wrote, led by Dr. Sietsema at UIC, and we wrote this with colleagues at NIOSH and CDC. And it was a thought piece, a control banding thought piece in preparation for aerosol transmissible diseases. Mostly the focus was on influenza, because that's what we've been doing for years, is planning for a pandemic related to influenza. And the purpose was, we knew from H1N1, novel H1N1, that we were going to have a shortage of supplies, especially personal protective equipment. And so the purpose was to try and encourage employers to start thinking about not counting on respirators and trying to think about how would we do controls using a control banding method that focuses on source and pathway controls rather than receptor controls. And as we all know, the first thing that happened, of course, was that healthcare, we said everyone in healthcare should all the respirators should be saved for them, and everyone else should be doing something else. So that's, and then they ran out of supplies. So just as we expected, that's what happened. Then I wrote a second paper that's in the Annals of Work Exposures in Health that looks at COVID-19 specifically and talks, it basically builds on the same model from the first paper. And this is what we proposed, that you could divide things up into 3 bands, and depending on where you end up which band you end up in tells you what you should do in terms of using source, pathway, and receptor controls. If you're in path A, you shouldn't have to use receptor controls. If you're in band B, maybe, but only if you've satisfied that all source and pathway controls are not effective. And you end up in the highest risk category, band C, then it might be prudent to add a respirator or a personal protective equipment to the whole combination of source and pathway controls that you're using.
Okay. Cliff,
so if we go to the next, oh, sure, go ahead.
I just want to make sure Cliff didn't have a follow-up question or wanted to clarify anything. Cliff?
Well, no, but I'll tell you, let's catch that one text question that we had, in regards to humidity.
Oh, okay. And how humidity levels are taken into consideration. I know you commented on it briefly, but you want to comment on that again?
So let me see. Humidity I talked about humidity in terms of particles. People have also asked me, does humidity matter when it comes to viability and transmission? Because there is evidence that humidity and temperature matter in terms of influenza transmission, for example. And we think that maybe one of the reasons why influenza is seasonal, that it's more viable at low humidity and low temperature than it is at high humidity and high temperature. There is some suggestion that SARS-CoV-2 is similarly affected by relative humidity and temperature. But I'll tell you, the evidence don't suggest that there's a seasonality or climate impact for SARS-CoV-2, and that's probably because we're all pretty naive with respect to this infection. So we're all susceptible. Eventually, if this human coronavirus becomes, more common, or if it enters the normal circulation of infectious respiratory viruses, like a lot of human coronaviruses do, then it is possible it'll become more seasonal, and there'll be climate and season effects. But I don't think that's the case right now.
What about the receptor? If we are in a low humidity environment, does that make us a better receptor?
Probably not. I think getting an infectious dose has to do with inhalation. And inhalation is not really impacted by relative humidity or temperature. It depends on the particle size. It depends on our breathing rate. It depends on the concentration in the air. So those are the things that play the biggest role in how much of how many particles we're going to breathe in. And its size really determines where they're going to land in the respiratory system. Okay.
Let's go back to the slides, John. So we got the first part of the control banding, the A, B, C buckets here, the bands. All right, let's go on to the next one.
Okay. So there are basically, maybe we want to go ahead just one more.
Okay. Yeah.
So I can show you what happens. So at the end of the day, this is what we're going to do. We're going to use this exposure rank and the risk rank to figure out what control band a job is or a task is falls into. And so I'll talk a little bit about the exposure rank, but in the as shown in the previous slide, but the risk rank has to do with toxicity. So usually control banding requires that you know something about the exposure and you know something about the toxicity. If we had better information, we could make an exposure limit, right? That's what you really want, is to have an exposure limit and a way to sample the exposure. And then you could compare those two. That's what we do in industrial hygiene normally, but we're missing exposure limits and we're missing good ways to evaluate exposure. So that's why we fall back to exposure to this control banding. This is a risk group 3 organism, SARS-CoV-2, which is similar to SARS and TB, for example. And that means you could end up with pretty serious outcomes, disease outcomes, and we don't have a lot of preventive vaccines, for example, or therapeutic interventions. So NIH has designated this as a risk group 3 organism. So let's go back to the previous slide and we could talk a little bit about exposure. And we tried to come up, so this was the area we spent the most time on trying to figure out how to make this both simple but relevant in terms of thinking about exposure. And we know that exposure equals concentration times time. That's the usual way of thinking about it. But concentration, as I said, you can't really measure it. So we sort of used what we called likelihood. How likely was it that you're going to come in contact with infectious individuals? And what does that likelihood look like? So unlikely, you won't have much contact. Possible exposure, you might have numerous contacts who could be infectious. And likely, you could be working directly with infectious individuals. That would be like if you're caring for patients, for example. So that was sort of a way to encompass concentration. And then duration, we just tried to come up with a very simplistic way of thinking about this: a short time, a moderate time, or a long time. And based on hours of the day, usually people work about 8 to 10 hours. So that's how we ended up with exposure. That gives you an exposure rank, basically. And then you go to the next slide, you now can see you combine that exposure rank with the risk rank and you end up with a band.
And can you give us an example? Can you give us an example of R4? We talked about that yesterday a little bit.
Risk group 4, they're rare, but the one we're most familiar with is Ebola. And it's because we certainly don't have a vaccine for it. And being infected, a very small number of people recover from infection from Ebola, but it's a very hazardous and high mortality organism. So these risk ranks were developed for doing research with organisms. If you're going to work with Ebola, you have to work under very, very controlled biosafety level 4 conditions, and there are not a lot of places you can even do that in the United States. So.
Mm-hmm. Okay, what I'd like to do here, Dr. Brosseau, is we're going to take a break and thank our sponsors at halftime here. We'll be back with Dr. Lisa Brosseau for the second half. We're talking COVID-19 and control banding, fascinating stuff. We'll be right back. Our marquee sponsor, Instascope. Do more jobs faster with the future of IAQ assessment technology, unlimited samples, instant results, and cloud-based data at instascope.co. Our association sponsors are the American Industrial Hygiene Association, Healthy Workplaces, A Healthier World at AIHA.org, the American Conference of Governmental Industrial Hygienists, Advancing Careers of Professionals in Environmental Health, Industrial Hygiene, and Safety, interested in defining their science at acgih.org. The Cleaning Industry Research Institute. See more deeply through science and research. Learn more at ciriscience.org. That's CIRI science.org. The Indoor Air Quality Association, promoting the exchange of indoor environmental quality information through education and research at IAQA.org. The Restoration Industry Association, the granddaddy of the restoration industry. Network with leaders at restorationindustry.org. the Institute for Inspection, Cleaning, and Restoration Certification, IICRC, at iicrc.org. Healthy Buildings America 2021, Honolulu, Hawaii, August 10 through 12, 2021. Learn more at hb2021-america.org. Our industry sponsors, AEML Laboratories, free shipping, great pricing, same-day results, and no rush fee. Learn more at aemlinc.com. Particles Plus, particle counters and air quality instrumentation. Count on us at particlesplus.com. Healthy Indoors Magazine, a free online magazine for industry pros and consumers at healthyindoors.com. And Gray Wolf Sensing Solutions are back with us at graywolfsensing.com. All right, let's get back to the second half of our interview. We've got Dr. Lisa Brosseau. Dr. Brosseau, we kind of got the background all together. Now, I think this is where we get into putting a specific case together here, where we actually look at using this in a specific situation. And I believe we're going to use a bus driver. So why don't you go ahead and tell John which slide you want, and we'll take it from there.
So there are a number of cases in both of the papers, but this is just one example. And bus drivers who are essential workers, actually I have to just say on a side, occupational health and safety professionals are also considered essential workers, which is the first time that ever happened in my life, in my professional life. But there were a lot of essential workers who are at risk and have experienced high rates of infection. Bus drivers and transportation workers are among them. So control band C, they actually fall, I think we have to go back a couple more slides because, right, this one. Because let me just illustrate how you end up with them being in control band C. So they interact with lots of people every day. They don't really know a lot about who's infectious or who's not, but if you have high rates of transmission going on in a community, you're certainly going to end up with some people on your bus who are going to be infectious, and you won't know, and screening isn't going to tell you. And they work long hours, 8 to 10 hours. So in that context, they end up in E3, the rank E3, exposure E3 level. So if we go to the next slide, that shows you how you apply the exposure level in the risk rank to get this control band C. And just a reminder, the control band C means do a lot of source controls, do a lot of pathway controls, but you might end up having to use receptor controls at the end of the day. And so if we go to the next slide, that shows you, and these are just, you can go ahead and push the buttons. This is an animated slide. These are just ideas, and some of them are based on what I know is really happening. Some are just my thoughts about what you might do. There have been places where they limit how many people can be on a bus. There certainly are lots of places that are requiring face coverings in public, on buses, and many other places. I want to be clear, though, face coverings are not going to limit the emission of small particles, so they have a somewhat limited efficacy. So those are source controls. Eliminate the source if you can, or limit the amount of time, or limit the number of them, and then you that's a limited. All of that is sort of limited in terms of its effectiveness. So in the way of path controls, you could build a separate ventilated enclosure, for example, for the bus driver. And my understanding is a lot of buses, the air travels from the back to the front. So that means all that air full of infectious particles from passengers travels up towards the bus driver. And so they're actually at most risk in the context of being in a bus. And they're there for the longest time period. So one of the solutions might be to give them a separately ventilated enclosure that ensures that they're breathing different air, clean air, throughout the time period that they're on the bus. And I have seen pictures of buses where this has been done. So this does seem to be a solution some people are trying. And if you live in Chicago and are familiar with riding buses, I rode many of them when I lived there. Sometimes bus drivers actually have to get out of their seat and help somebody or fix the door or do something else. And so if you have to leave, the bus driver has to leave that enclosed space and you want to protect them from exposure, then the only way to do that is to have them wear a respirator if they're coming in contact with people riding on the bus. So that illustrates how you would use this control banding approach to select controls for somebody in control band C.
So this would be sort of a hierarchy. I mean,
Mm-hmm.
of course, you'd want the source controls first, and then if they're not enough to make it safe, or whatever terminology you want to use, we go to the path controls, pathways. And if that's not enough, then we go to the receptor controls. And this can be done for any job, I guess.
Absolutely.
And that's the whole point of the control banding, is that it can be used. How does this compare to like a hazard assessment or a risk assessment? Is that?
Yep, it's the same thing. It's just
Okay.
It's more qualitative in nature, right? Because you don't have exposure limits and you don't have methods for measuring people's exposures. So you're making good guesses on using your professional judgment to make some good estimates of what people's exposures are and how long those exposures occur, and then putting them, sort of prioritizing them.
Okay, let's go first to the chat. The Chinese put in controls including higher level PPE towards Ebola requirements. With HCW, should we be pushing higher level controls towards those required for Ebola? And would you perhaps share whether there should be a gradation based on the level of community transmission? Good question.
Two questions. Well, so the higher level of personal protective equipment for healthcare workers, absolutely. I don't know if it needs to go all the way to the Ebola because that was, but Ebola was a problem if there's contact with any body emission. So you could find live virus in most body fluids. And that's not entirely true for SARS-CoV-2. But, if you're worried about contact hand-to-mouth transmission, then wearing gloves certainly makes sense. If you're worried, you should be worried about aerosol transmission and inhalation, so you should be worried about wearing a respirator. We do have some concern about ocular transmission and possible infection that way. So certainly wearing protection on your eyes, especially if you're working closely with patients, whether it's goggles or a face shield or something. I don't know about the whole rest of that gear. They basically covered over completely, and I think a good shower is probably just as good as wearing complete personal protective equipment. But healthcare workers are used to wearing lots of PPE, so certainly a gown isn't a bad idea. But I don't know if you need a full tie-back suit. The thing is though, what the Chinese did once they realized there was healthcare worker transmission is they did require respirators. And respirators are not being required by WHO, except in the case of healthcare workers performing aerosol generating procedures, AGPs. And that's unfortunate and wrong, I think. Anyone who's exposed to somebody who is potentially infectious should be wearing a respirator, any healthcare worker. And there's a lot of transmission going on in healthcare settings, coworker to coworker, and with people who are not thought to be infectious, but perhaps are infected because they're asymptomatic. And so I'm thinking, I personally think that there should be more people in healthcare settings wearing respirators than are wearing them right now. And the only other thing I've said, and I've said this since the beginning, and I said this about Ebola as well, is that if you are doing aerosol generating procedures, you shouldn't be wearing an N95 filtering face piece respirator. You should be wearing something better than that.
I'm so glad you said that.
Full face piece respirator, full elastomeric full face piece respirator, or better yet, a Parader purifying respirator, because it's more comfortable.
it does seem like that's taking hold a little more when I see these interviews and video of people working in hospital. I am seeing more half masks, even more PAPR type respiratory protection. How about the second part of that question? I lost you there for a second, but what about the gradation based on the level of community transmission?
I'm not sure I understand that question. Can you explain that a little more?
I'm thinking, I didn't ask it, but would you perhaps share whether there should be a gradation based on the level of community? So how would you adjust, I guess, the control banding based on transmission in the community?
Good point. Well, think back to that bus driver example. And when I was talking about their exposure, if you have low community transmission, then the exposure level might be different than if you have lots of community transmission, where the potential for anyone getting on the bus, it could be infectious. That might push your exposure level or your the likelihood of exposure up to a higher level. So that's how I would use it to adjust how to select exposure, and then how to use that to make decisions about the control band. And it might be that moving it up pushes you into a different band, although the bus driver's already in the highest band, but it could push somebody else who's in a lower band up to a higher band.
Gotcha. Now I've got one that I know Cliff is going to love here. Other than humidity, can indoor air be treated with disinfectants or other types of products to limit the travel of aerosols from person to person? And Cliff's he's done a lot of work on this, and especially in sanitizing and disinfecting of spaces, but I don't think it's just that. I think it's also maybe using some other, for instance, in a couple of weeks ago, Cliff had a humidifier going behind him in the room. What are your thoughts on that?
So, yeah, I'm not an indoor air specialist, but I will tell you, filters are great. And everything else is sort of silly in my mind. It's a waste of money. So if you're going to clean the air, all you need to do is put it through a really good filter. You don't need to worry that the organism is killed, because once it's on the filter, after a little bit of time with air running past it, it's going to be dead. It's not going to be viable. So a good portable air cleaner that generates a higher air, helps you generate a higher air exchange rate in the room, is a really good purchase, I think. And I bought one for my home simply because if somebody gets sick and they have to isolate, and you have to go in periodically maybe to interact with them, in addition to wearing my respirator, I admit I have a respirator, I would want that air to be as clean as I could get it, and a portable air cleaner with a good filter is going to be great. So but the whole, the whole disinfecting of every surface multiple times a day, some of my colleagues call this hygiene theater. It's really not necessary. I mean, it's overkill. It's a waste of time. What we really should be focused on is washing our hands, because what the problem really is transmission from hands that are contaminated to mouth or face or nose or eyes or whatever. If you wash your hands pretty frequently, then you can be assured that that's not going to happen. And you don't need to use a lot of crazy stuff on your hands. This organism is actually rendered non-viable by soap and warm water. And experimental data have shown that. So the amount of spraying of insecticides and pesticides and sanitizing and all of this, it is what I think I call it. It's a hygiene theater.
Okay, Cliff, you've got a follow-up, I think.
I do. I don't disagree that filtration is very important. It just seems that our society has a tendency to always go for the newest thing, and oftentimes it's the most expensive thing. And I agree with the doctor about this hygiene theater, that everything doesn't have to be disinfected and continuously disinfected and so on and so forth. But in response to the question, the EPA, and I'll put it into the blog, but the EPA has known for a long time, and this research goes back to the 1940s from England, when during the bombing, people went into bomb shelters, which were primarily subway stations that were underground, and they had thousands of people crowded really close together. And if you think about it, this is 2 decades after the 1918 flu epidemic or pandemic, and people were quite concerned. And what they did in these environments is they vaporized propylene glycol and triethylene glycol and so on and so forth. And for the most part, these are food grade products. Triethylene is not, but propylene and dipropylene are. And that's what's commonly used now in vaping. And by adding that to the increase in humidity that was in the air, they found that it was really, really effective. So I'll put, again, the information in the blog. It's been in past blogs. And, I'll put a complete list of references, and you can kind of read up on it, make your own decision. But I do think you should just read the information and make your own decision.
Let me ask you a follow-up on the use of portable air filtration devices. I have seen industrial hygienists and others express concerns about the exhaust from the portable air filtration devices, possibly re-entraining viral particles that are, that have settled out of the air and so on. What are your thoughts on that?
I don't know how that would happen. So, if you're moving air through the air cleaner, you're basically causing a circulation to occur, right? I'm not that worried really about entrainment, re-entrainment, as much as I am about capture of what's in the air. And in most homes, right, or even residential, like my condo building, the air changes per hour are very low, 1, 2, maybe, if we're lucky, right? So you put a portable air cleaner in a room, you could enhance to 3 or 4 air changes per hour. That's not a bad thing. That ensures that you're turning over the air more frequently, and with an air cleaner, you're capturing particles, actually. And once captured, as I said, they're there. They're not going to get emitted from. All these particles are pretty large. I use that term in quotes because I think of particles less than about 5 microns as being small, but some people think those are large. But these are particles that are they're captured with pretty high efficiency in a HEPA high efficiency filter. So, and everyone worries about the size of the virus, but the size of the virus is not the thing we should be worried about. It's the size of the particles that we generate. And those are usually maybe as small as 0.5, but usually around 1 or greater in size. And those are captured with very high efficiency.
Okay. I've got, Cliff, you got a follow-up, and then I think we've got to go to our roundup and wrap things up.
Yeah, I do. I'll do my roundup question now, Joe. But a couple of shows back, Joe, I don't know if you remember, but it was the person, he was calling us from his cabin and, up in the mountains, and he made a comment about the corner of the living room or whatever. And the bottom line is, what he said, doctor, is that this corner of the living room is the most unlikely place. And what happens is that's where people put these air cleaners. They put it in the corner of the living room. And what happens is they're living and working away from it. It probably should be on their desk or within their breathing range or close to them, because they do have very small zones of efficacy. So I just wanted to just add that comment.
Yep, you're exactly right. Where you put an air cleaner matters a lot. I agree.
Let me finish up with this topic and a little general discussion. We didn't talk much about face mask versus respirators and so on. And I know you're not a big proponent of face masks. You you recognize, because of your years of experience and research with respirators, that there are issues with these face masks. But what I'd like to kind of do is get you to talk to listeners about, because we're going to be having face mask requirements for at least probably the next 6 months. What can we do to do a better job, or what can we do to ensure that the face masks that people are going to be wearing anyway are at least giving them some help?
Good question. The problem is with face coverings are made out of cloth or woven material, and that's what we call a mechanical filter. And the only way to get a mechanical filter to work really well is to have lots of layers. And the problem with increasing the layers is then you increase the breathing resistance. And so the problem that I have with this is, and I've looked at lots of studies, so-called studies of face coverings, and they always recommend at least 3 layers of cloth, and sometimes they say you should put like a vacuum cleaner bag filter in between. I have to tell you, those things, no one will wear them. They're very hard to breathe through. What they're going to wear are these 1 or 2 layer face coverings and they have to be cool, right? So people are buying these things that have messages or pictures on them, but these things are very, very ineffective. So my job, I haven't been focused on trying to get them to be better or more efficient, because I don't think that's possible. And I really don't think that people will wear them even if I could design them. And there are plenty of good designs out there that could be better. But my focus has been to say, certainly you should wear your face covering because it's required. But please just don't count on it. Don't expect it to protect you for very long or when you're close up to someone. Don't spend a lot of time in, small, poorly ventilated spaces with lots of people whose infection status you don't know. They're not, and please don't think of them as replacing or being a replacement for physical distancing, for example. So, as much as the CDC has espoused their magical properties, that is all it is magical thinking. Face coverings are not going to flatten the curve. They are not going to prevent people from getting an infectious dose. They limit your time to infectious dose by minutes, not by hours. And so it really is important that people just understand that these are not anything to count on. But I don't say people shouldn't wear them. I simply say, be careful when you do. Continue to do all those other things you should be doing.
And before we go, how do you see the progression of things as we get back to normal? What do we need to be careful about, and what should we focus more on, I guess? And pick or choose whichever you'd like to answer.
Yeah, well, this is a ventilation. I mean, your one of your focuses is on ventilation, I'm sure, as an IAQ radio. I personally think we have to do a lot more and better with respect to ventilation. And when I talk about ventilation, I mean under the ceiling, not in the HVAC system. We've got some good recommendations for HVAC systems from ASHRAE, but we need to do better with respect to what should we do to protect people using ventilation in indoor spaces. And I mean all the indoor spaces that exist, ranging from offices all the way to manufacturing settings. And it's different and it's complicated, but I think we all have the tools as industrial hygienists to make that work. We just have to put our minds together and maybe do a little research and come up with some better recommendations for ventilation in indoor spaces.
Excellent. And before we go, is there anything you'd like to add?
No, thank you. These have been great questions.
Well, thank you for joining us, Dr. Lisa Brosseau. We really appreciate Lisa. I got it right this time. All right, Dr. Brosseau.
No
Thanks
worries.
so much. It's been a real pleasure getting to talk to you a little bit and get to know you a little bit over the last couple of days here. And we really appreciate you joining us. This is Radio Joe Hughes saying thanks to this week's guest. I also want to thank the Z-Man, Cliff Zlotnick, my co-host. John, you got to have faith at the controls. By the way, next week, we've got Dr. Jay Portnoy from Children's Mercy Hospital in Kansas City. We're going to talk to him about COVID with children and also how the general COVID issues have affected their hospital. Plus, Dr. Portnoy is an expert on mold and mold allergies, so we're going to talk to him a little bit about that as well. Please come back and join us next Friday at noon for the next episode of IAQ Radio Plus.
For IAQ Radio, I'm Spike Reel saying thanks for listening.